Yeah. Can you hear me?
Yes,
Yes.
ma'am.
Can you hear me? Okay. So
Yes,
I'm
ma'am.
going to talk
Yes.
about optimizing IUI outcomes in clinical practice. And I think this is so important for all of us as gynecologists treating infertility, where IUI is there for level 1 clinics now through the ART Regulation Act. And most of us want to do an IUI, whether it is in your own clinic or in someone else's clinic. So let us look at the evolution of IUI in humans. First, it started originally with the partner semen for couples who had a male factor disability, physical or psychological in nature, that they could not deposit semen into the female partner. Then came in the era of donor insemination, and we realized that any one semen can be inserted into a woman's vagina to cause a pregnancy. And this was generally done when the partner was esospermic or very low sperm count in the days when IVF was still in its nascent form, or there was an inherited genetic disease, especially linked to the Y chromosome. And then came the recent era where we do it with the partner semen, mainly for unexplained and mild male factor infertility. So look at the indications how they've changed. At first, there was inability to insert, then we came to donor, but we never thought that unexplained infertility and mild male factor infertility will benefit with IUI. What is intrauterine insemination? We know that the rationale behind IUI is to increase gamete density at the site of fertilization. When I say gamete density, it does not mean sperm density only. It means oocyte and sperm density. So what happens that we need more than one oocyte also, and then we need a concentrated pellet of sperms reaching the tubal fimbria at the site of fertilization. Even when sperm or cervical mucus anomalies are present, we can go ahead and do an IUI. And this was Practice Committee ASRM in 2006, when IUI really established itself as a very important method of pregnancy. But then IUI underwent a roller coaster ride. What was this roller coaster ride? Why did it happen? Suddenly, after 2006 to 2012, everyone was happily doing IUIs, when NICE guidelines in 2013 said that intrauterine insemination with or without ovarian stimulation should not be routinely offered to couples with unexplained infertility. And IVF can be considered after 2 years of expectant management. However, in 2015, a survey was done of all UK fertility clinics, and it was reported that 96% of clinicians still continue to offer IUI. But what happened by this guideline coming out by NICE, all funding for IUI in several London clinical commissioning groups, CCGs, was immediately stopped. So patients would not get any funding for IUI, and hence they would just sit tight, and yet IUI continued to be used by clinicians. Where did the UK people say that you can sort of do an IUI? Those who were unable to have vaginal intercourse, specific consideration when sperm washing is required, such as for a HIV positive man, and if people were in the same sex relationships. That means two women together would need a IUI for semen to reach them. Only in these three conditions, the NICE guidelines allowed the insemination to be done. But this was rejected by professionals. And in 2016, the two doyens of IUI, Professor Roy Homburg and Ghulam Bahadur, they brought out an article in Human Reproduction, and they said first-line fertility treatment strategies regarding IUI and IVF require clinical evidence. They said we cannot go without clinical evidence and just delete IUI from our armamentarium. And they said national funding strategies include IUI for most first-line treatment options, and the UK NICE guidelines need a radical review of IUI procedures. They also said that the evidence of financial, economic, and clinical considerations presented within this commentary strongly favors IUI as a first-line treatment option for subfertility. So after having said that, then there was ESHRI in 2017, and two landmark papers were presented. one by Cindy Farquhar, who's from Auckland, a very famous name. And she did a RCT with 201 couples with 3 to 4 years of unexplained infertility. They were randomized to receive 3 cycles of IUI or expectant management. Live birth rates with IUI were 31% vis-a-vis 9% with expectant management, where you tell them, okay, just have intercourse when you ovulate, and that's all. So there was a threefold difference in outcome. At the same time, same conference, one more landmark paper came up in BMJ Open Journal by Danoff from Netherlands. And they said that it was called the super study, and this was a randomized controlled trial comparing follicle stimulating hormone and clomiphene citrate for ovarian stimulation and intrauterine insemination. And they came out that clomiphene is also very good, even though clomiphene had a slightly lower pregnancy rate of 26% in very well selected women, and gonadotropin had 31%. But for such a small group, it was not statistically significant. 113 women in the gonadotropin group and 97 in the clomiphene group. So ongoing pregnancy rate following IUI with clomiphene was equivalent, as there was no statistical significant or significant p-value loaded. So 2017, the whole thing started changing again after 2013 NICE guidelines. And this is again William Omelette, whom I think is my guru for giving us rules for IUI. And he said he organized a campus meeting IUI workshop. And he said, if the tubes are open, there is no reason not to do IUI. And he is also, Professor Omelette is the chief editor of Vision and what is it? Myths and Facts. So his turning point editorial by the editor-in-chief has again turned the tables in favor of IUI. What did this editorial say? Well, he said revival of IUI, evidence-based data have changed the picture. And according to a number of high-quality studies, intrauterine insemination with homologous husband semen should be the first choice of treatment in case of unexplained and moderate male factor subfertility. IVF and ICSI are clearly overused in this selected group of infertile couples. So let us see what are we doing. Now let us see how we can improve our pregnancy rates in IUI. We know we have three oral ovulogens, letrozole, clomiphene, and tamoxifen. Tamoxifen, for some reason, has never caught up on our pens, and we have never been able to prescribe it. It does cause multifollicular response like clomiphene. Letrozole has a drawback that it generally causes monofollicular growth. And we are talking of unexplained infertility. We are not talking about PCOS. In PCOS, letrozole also can lead to a multifollicular growth. But we are talking of women with unexplained infertility or PCOS who have not conceived after having had good ovulation and timed intercourse for 6 cycles or maybe more, and they've not conceived. Then we take them for IUI, but we treat them like unexplained infertility because all those cycles they've ovulated. They've had a chance to have sexual intercourse. So when they come to us for IUI, then it is not because of PCOS we are taking them for IUI. We are taking them because we don't know why they are not getting pregnant despite good ovulation. And the last drug is controlled ovarian stimulation with low dose gonadotropins. And I, in my practice, has seen that low dose gonadotropins bring us the best results. However, for those who are not very conversant with using gonadotropins, still we have oral drugs which would give you substantial IUI pregnancy rates. Now, this is a very important review which came in Human Reproduction Update journal with the highest impact value in 2018. And here our IUI guru William Omelette was the chief author under whom the whole global recommendation by WHO was taken. And this was a PICO uh, study, which means population intervention, control, and outcome format. It is considered a widely known strategy framing a foreground research question. So having said that, this was done, and I'll just bring you few important points in this whole thing. They have 21 points, but I'm going to bring you only the important ones. One is clomiphene citrate or tamoxifen. So what they've given in this review, two drugs, clomiphene and tamoxifen, are acceptable alternatives to low-dose gonadotropin for low multiple pregnancy and birth rates with lesser cost, although at a lower live birth rate than when compared to gonadotropins. Agonist and antagonist are not recommended. So we do not need to add or control ovulation by agonist or antagonist because there is no increase in pregnancy rate despite increased multiple pregnancy rates and increased cost also. A very good practice point is, suppose you've stimulated your patient with gonadotropin or whichever drug, and you've got 3 4 dominant follicles coming up. What they suggest, it's not easy to convert a IUI patient to IVF. I have seen it all my life. Patients need a mental preparation when the word IVF comes in front of them. So what you can do is just take them in the OT, use a aspiration needle, leave 2 follicles and aspirate the rest. At least they won't ovulate and multiple pregnancy will not happen. How can we prevent multiple pregnancies and ovarian hyperstimulation in IUI program? In order to prevent high rates of multiple gestation pregnancy in IUI ovarian stimulation with gonadotropins, IUI should be withheld when more than 2 dominant follicles are more than 15 mm. When we say 2 are more than 15 mm, which means that we are going to give a trigger and already 1 follicle has reached the trigger size, that is 18 mm, or when more than 5 follicles are more than 10 mm at the time of HCG injection or LH surge. Say if LH surge is happening and 1 or 2 follicles have reached 18 mm and there are 10 more than 10 means 11, 12, 13, 14, then also withhold IUI. However, because we allow sexual intercourse, there is still a chance that these girls could get pregnant with just sexual intercourse and not IUI. So we have to be cautious if they have had sexual intercourse before the IUI. And when gonadotropins are used, please beware, use regimens with 75 international units or lower should be used because higher doses have similar pregnancy rates but increase in multiple pregnancy rates. If there are very poor responders or very poor reserve patients, you can go up to 100 or maybe 125, rarely to 150 with monitoring. So we have to beware of multiple pregnancy. And what happens in a natural cycle, there is a whole cohort depending on what the reserve is. And then as soon as estradiol is produced, FSH is suppressed from the pituitary and all the follicles are suppressed into atresia and one grows to ovulation. In IUI, our aim is just this, that more than one goes to ovulation, but we don't even want three because triplet is again a disaster. If there are three, it could be twins, it could be single, and it could be triplet also. So the risk is not worth it. The starting dose for gonadotropin is based on age, her BMI, presence of underlying PCOS or maybe history of hyperresponse, test for ovarian reserve indicating poor reserve, and previous history of high response or poor response. Having said that, if she's a hyper or normal responder, starting dose should be anything of 50, 62.5, or 75, which I use in my clinical practice. And for a poor responder, the dose can be from 100 to 150. Now, we all have read through our whole courses that there is a constant dose gonadotropin, there is step up and step down. Now, what do we do when we start gonadotropins in unexplained infertility for IUI? The first ultrasound monitoring happens on day 2 or 3 of the cycle when we are going to start gonadotropin. And then we call her after 5 days, exactly like an IVF, which means day 7 or 8. And then, depending on the follicular size, we may have to call her in 10, 11 days. Why am I saying this? Because these are women of unexplained infertility who ovulate in 28 to 30 days. So they will ovulate by day 14, 15, or 16 latest. So if we are stimulating them, generally by day 11 or 12, the follicle is ready to be ruptured. A 18 mm follicle or 19 mm follicle is there. Now, if you are doing a urine LH test and it is positive, IUI is done 24 to 36 hours later. If we are giving a HCG trigger in absence of a LH surge, then IUI is best done after 40 hours, and I will tell you why. Now, here, this is a no-no for IUI regimes. Why is it a no-no? Because after day 5, if you increase the dose also, it is already day 7 or 8 of the patient. And in unexplained infertility, where the cycles are normal, you will not be able to bring up the second follicle. All the other follicles are around 10, 11, and the dominant follicle is going up to 15, 16. Even by stepping up the dose, you may not be able to bring up two follicles for ovulation. So either you go for a constant dose, and even if you find one follicle, it's your bad luck. You do IUI with one follicle. Next time, increase the dose in the beginning so that you have two dominant follicles. Step down is important because if you find that suddenly a cohort of follicles which is growing is 12, 12, 13, 13 mm, 4, 5 follicles, immediately step down your dose by 25 or 50 units for the remaining days of stimulation, and you will find that some of them which have not gained dominance will undergo atresia. Why is learning the right ovarian stimulation so important? Because it is unacceptable to have a high multiple pregnancy rates. I will tell you my own experience. Just about 1 week ago, I had to do a suction curettage for a patient whom she was a PCOS, and I gave her letrozole for 5 days, thinking that this will do. And then my assistant saw on day 12 there was nothing which came up. So she gave her 3 injections of Folisurge. And then she comes back, and then we sent her home and we said, you have natural intercourse. She came back with 5 sacs. And after 2 weeks, we found there was cardiac activity in all. So we just did a termination for her. We did not think of reduction because reduction does not work. So you have to be very, very careful about high multiple pregnancy rate. And I've heard a lot of very important people saying that in IUI they use 150 to 225 units of gonadotropin. I do not understand how do they prevent OHSS and multiple pregnancy rates. Clinical complication of multiple pregnancy affects the maternal perinatal morbidity and mortality, and clinical complications of OHSS may lead to intense maternal morbidity at a time when she should have been happiest and welcomed and enjoyed her pregnancy. She's admitted, she's, bloating, she's nauseating, she feels what has she gone into, what has hit her to get pregnant that she's in such a bad condition. Now I come to timing, and this is from the same evidence 2018 by William Omblet, the WHO PICO analysis. When is the best timing of insemination in an IUI cycle? I'm giving you their view, and then I'll tell you what is my view. What is the optimal method of timing in natural cycles or stimulated IUI cycles? Now, natural cycle does not come into play because even in mild male factor, now we want stimulated cycles. So providers can determine the method of triggering an IUI stimulated with gonadotropins, as there is no evidence to recommend for or against a method. If you've got only two dominant follicles, the LH surge is good enough to handle the whole luteal phase. But if you have more than two, you will have to trigger because you need HCG then to handle more than two follicles which will rupture, and we don't want them to lyse during the luteal phase because LH does not support more than one or two follicles in a cycle. If a HCG injection is used, single IUI can be performed anytime between 24 and 40 hours after HCG injection without compromising on pregnancy rates. So looking at these two is when we are stimulating and when we are giving HCG or triggering. Then why pregnancy rates are low with IUI? I'll give you very, very nice explanations for this. One is that we might not have selected our case well. We may have been too early or too late for IUI, hence improper timing may lead to lower pregnancy rates. And I think we need the same precision for IUI as we need in IVF. Oocyte retrieval, you do it at 36 hours or 35 and a half or 35 or 36 and a half, and you still wonder that will the follicles rupture? Are they mature enough? Will I retrieve enough follicles? So those 2 hours are so critical in oocyte retrieval. Therefore, even timing of insemination in relation to ovulation and sperm collection is very, very important. Now, have a look. This is a very favorite slide of mine. When we say we are doing IUI for unexplained infertility, all we've seen is we looked at the male factor, saw the semen was okay. We looked at the female factor, we saw the infrastructure tubes were open, and we saw that she was ovulating. That is all. When we do IUI, we reach the sperms here. That's all. and the egg is here or it is not here, we don't know whether the fimbria has been effective in picking it up or no. So what is unknown is all this area is unknown for us. We don't know whether the egg was there, whether the sperm reached and fertilized it, and all this, the cell division, the 2 to 4 to 8 to 16, and morula and blastocyst formation all happens while the embryo is traveling in the tube. All this we are blinded to, and which we know in the IVF laboratory. In the IVF laboratory, we see all this phenomena. The only thing we are blinded to is when we put in a blastocyst, we don't know now whether it is going to find an implantation surface and implant or not. And this is the reason that as IVF culture methods and clarity of how to do in vitro fertilization improved, the pregnancy rates also went up to 60%. But in IUI, they still remain revolving around 20% because all this phenomena is absolutely unseen for us. We do not know in those two sites which have been uh, released whether all this is happening or they get stuck in the way like they get in the IVF laboratory. Yes, body is a better incubator, perfect temperature, perfect environment, everything is perfect, yet a lot of embryos would get arrested like they get arrested in IVF. So I always say that IUI will always have a limitation that so much phenomena is understood. And you have to understand that there are few facts associated with semen collection, wash, and insemination. We understand that the moment we remove seminal plasma from the sperm in a laboratory where we are separating the sperm from the seminal plasma, it changes the ions in the acrosome. Washed sperms fertilize oocyte only within 2 to 3 hours from preparation time. What happens by changes in the ions in the acrosome? All the X factors are removed, which stop the sperm from becoming active, which don't let the sperm get capacitated. The moment we remove all that, the sperm capacitation starts. And then they are there only 2 to 3 hours because in that time the acrosome will get lost. No sperm reservoir is there in cervical mucus in IUI. Only after natural intercourse there is a reservoir. So having said that, this was in a editorial Journal of Obs and Gynae in India, 2009, which told us all about sperm then. So 2009, we know that, the moment sperm is collected, process it and put it into the woman, because after processing, the capacitation will start. Now, there are facts associated with timing of ovulation. WHO probit analysis of natural cycles. What is probit analysis? It is undertaken with the use of proportion of women who had ovulated at a given time in relation to the interval from the peak rise of a hormone, which is LH. So if we say that, then probit analysis shows that ovulation happens when the LH surge starts. It can happen within 24 hours and it can take more than 2 days to happen also. Ovulation after 36 hours and sequential over several hours up to 48 hours after HCG injection if LH surge has not started. Please remember these two things, that if we look at LH surge, ovulation could happen in 24 hours, but in some patients it would happen later and we would miss the train for those patients. Whereas after HCG injection, also ovulation will start in 36 hours. Like in IVF, we pick up eggs at 36 hours because by that time nothing ruptures, and it will happen sequentially if there are more than one, two, or maybe even three. So oocytes after being released are fertilizable within 12 to 16 hours only, after which they start disintegrating. If they don't get the complement chromosomes from the sperm, they will break down. So we have a window of 12 to 16 hours after they are released. So if they are released in 36 hours, we have at least saved 12 hours when we can sort of do an IUI and we expect our oocytes still to be healthy, sitting in the tube waiting for a sperm to come. So 36 to 48 means 12 hours. So what is the most favorable window of insemination? Oocyte viability is 12 to 16 hours post-release. So 46 to 48 hours post-HCG trigger, as ovulation will start by 36 hours. And if there are more than one oocytes, they will all release sequentially. And we feel by 48 hours, whatever has to be released will be released. So if we do IUI at that point, when we feel that all the oocytes have released, then we'll be able to capture all the oocytes which are picked up by the tube in absence of a LH surge. Semen viability, we all know collection to insemination, if possible, less than 3 hours. And this is again a picture which I like. And this is the window where we see that the egg is picked up and the sperms can come and hit the egg. And this window is 12 to 16 hours post ovulation. So after 16 hours, the oocyte will start disintegrating and the sperm will not be able to fertilize it. So if the oocyte is released for 36 hours, we are safe till 48 hours. If the oocyte is released at the LH surge, we do not know whether ovulation will happen after LH surge in 24 to 48 hours. And that is why a lot of people like to give a trigger. But if I give a trigger, I do a serum LH because our LH results are available within 2 to 3 hours. So having said that, I again come back to the 2018 update. What is the optimal number of inseminations per cycle? Well, women undergoing IUI should be offered single insemination per cycle, which has moderate degree of evidence. And both unexplained and male infertility, there is insufficient evidence that the intervention, a double IUI within the same cycle, will lead to better pregnancy rates. There are studies which say better, there are studies which say poorer, which there are studies which say same, but we have to look at the strength of the study, whether it is randomized control, what were the numbers, and then they come to this type of a conclusion. Is there benefit of bed rest after IUI? Well, they have come back to this that women undergoing IUI should have 10 to 15 minutes of bed rest after an insemination. So this is a new thing which has again reinstated, and we do follow it. What is the ultimate number of consecutive IUI cycles per couple women in which pregnancy rates still increase significantly? In couples with indication of IUI, at least 3 consecutive IUI should be performed when we expect pregnancy rates to rise. After that, we do not know whether it will rise any further. There is no evidence to recommend maximum number of IUI treatment cycles. We used to do 6, 8, 10 also in the era when IVF used to give us a 20-25% pregnancy rate. But now, no, IVF has moved way forward in terms of live birth rate, and IUI is still dwindling in the same for reasons which I just told you, that there's so many unseen events happening in the body of the woman. We do not know whether embryo or blastocyst really formed inside her or not. With semen preparation technique, any technique, whether it's swim up, gradient, wash, everything. What is the cost effectiveness of IUI versus IVF ICSI? Definitely IUI OS 3 cycles vis-a-vis one IVF ICSI. IUI takes the leadership in the cost because it is much lower. And this is especially if the total motile sperm count is more than 10 million. And a prognosis of pregnancy without any assistance is less than 30%. That means you do an analysis, you see what is the probability of the patient getting pregnant on expectant management, and if it is less than 30%, and if the post-wash count is more than 10 million, please go ahead with IUI. So now, again, there were more reviews, there were more articles, and this is again a review, systematic review and meta-analysis. And this came out after the 2018 William Omelette review. And here they said, for every birth gained with the use of gonadotropin, a similar increased risk of multiple gestation occurs, because that care which is needed with gonadotropin is very difficult to achieve by most of us. The randomized data do not support the use of gonadotropin for OS-IUI in women with unexplained infertility. They say that use clomiphene, use oral drugs. They are good because even though they give a lower pregnancy rate, they don't lead to much of multiple gestation. So controversies continue in the roller coaster ride of IUI. First, we came up to whether IUI should be done or not. Then everyone proved that IUI is a very good option. Then it was gonadotropins are the best. But now articles are coming up on oral ovarian stimulation versus gonadotropins. So the take-home message is IUI with ovarian stimulation is recommended as the most cost-effective strategy for mild male factor or unexplained infertility with a poor prognosis of becoming pregnant with normal coitus. So you have to see what is the probability of this woman to become pregnant just with expectant management. And if it is low, IUI is a very good strategy. There is no strong evidence in support of offering IVF as the first line strategy in couples with unexplained and mild subfertility. So we all understand newer developments must continue, but old can still be gold. Thank you very much.
Thank you so much, ma'am, for such a comprehensive and informative lecture on IUI. Now we shall be taking the questions one by one. The
Okay.
first question is by Dr. Mayank Jain. Why to check serum LH if we have given HCG for trigger in IUI cycle?
Now, Mayank, this is a very nice question. You can give HCG closing your eyes, but say what happens if the LH surge had started? If LH surge has started and you've given a HCG, you will be in the impression that I've given a HCG, so I'll do a IUI at around 40 hours. But LH surge has started in 24 hours, she will ovulate and you will be very late for IUI. That is why I feel that serum LH is very important. But people don't recommend it, neither do everyone has the facility to get the report instantly. So a urine LH surge is done. But then urine LH surge, we know that we can miss because the surge can start in the morning, afternoon, night, and we might get a negative LH surge even though the surge has started in the morning or it is going to start in the evening. That is why. You have
Ma'am,
a
when are we doing the LH search, LH test? At what time are we doing it?
who's asking this?
Ma'am, Latika.
Latika. See, what I normally do in my, Bhavani will tell you what we do in our clinical practice. The moment I find that a follicle is on gonadotropin 17, 18 or 19 when the patient comes, we just send one LH if we are giving a HCG trigger. And that LH report we get in 2.5 hours. So suppose it is still less than 10, whatever the basal LH was in the beginning. We don't do LH every cycle in IUI. We just do ultrasound and a E2 check. I like to do a E2 check because very high E2 shows a luteal selection of a follicle. And these cycles culminate very rarely into pregnancies. So do a LH, you get the report in 3 hours. Okay, LH is less than 10 or less than 12, you give a HCG trigger. And that is it. So you do it when your follicle is big, but if you find the LH already reaching 18, 19, 20 or more than 20, don't give a HCG trigger. And if you still want to give it, then you do your first IUI in 24 hours after the LH surge.
And ma'am, particularly in donor semen IUI LH testing is very important because natural contact will
Going
not
to lead to any sperm
help.
deposition, correct. In donor cycles, even Bhavani, 2 inseminations have been recommended when you've not done a LH search and you're not sure about what is happening. Now, how to calculate probability, ma'am? Whose question is this? This is a very good question, and I want Bhavani to answer it. How do you calculate probability of getting pregnant on expectant management?
Ma'am,
What are the models?
there is a Hunold scoring system
Yeah.
where they have given various parameters such as the female age, the duration of infertility, whether primary infertility, secondary, and the
Tube
sperm
is fatal.
count.
Tube is
So depending upon these four factors, the scoring is done, and the higher the score, the poorer the prognosis. So
Please,
there,
on the forum, you write this
I'll
Hunal's.
put the Hunold score.
And
So
not only Hunal's, then you can also put the modified Hunal's, which was done
which has more factors, which takes into account sperm count, FSH levels, BMI,
right.
other parameters also.
Right. So, Latik, who was this? Who asked this question? How to calculate probability? Please unmute yourself. You can talk because I would be very happy if all of you talk and tell us your doubts.
Ma'am, I'm Dr. Nayana from ma'am. I'm doing FNB in MAMC.
Okay, very good, Naina. So please go through this thing, the probability methods to be calculated. There are 2 methods. One is Henols and the other one का नाम बोलो क्या है? P से है ना?
Bensdorp.
Bensdorp and Henols. Please open that, read it. It is very, very important to see how do you calculate the probability in a woman of her being pregnant. And if the probability is less than 30%, she needs intervention. If the probability is more than 30%, she can be left on expectant management for as much as time you want. Now,
The
Surendran, yeah, If the patient wants natural cycle IUI, at what follicular size should we start monitoring LH, and how often serum LH or urinary LH kit is done? See, natural cycle IUI, why will a woman want? You will tell her it is of no use because you don't know why she's not getting pregnant. Is it the sperm's not reaching the egg, or it is something else? So you need more eggs also. So please counsel her and tell her that you don't want injections. I will give you a tablet to increase the number of eggs you release. And then also you can do a, if you're doing a urinary LH, it is best to do in the afternoon, because generally the surge starts after 12 noon in 50%, and the rest 25% early morning or late night. So if you use a urinary LH kit, you can tell her to do it from follicular size 18 in a clomiphene cycle, because follicle generally ruptures after 22, 23. So she can do a daily monitoring if you think that you want to do. But natural cycle is not advocated at all. We need both side gametes to be increased because we do not know who is the culprit. Any other answer for this? Anyone wants to
And
give?
what is your opinion on natural cycle IUI in donor semen cases?
Yes, this was the recommended treatment, that natural cycle IUI should be done in donor semen. But now, even for donor semen, they say stimulate the cycle, she'll get pregnant faster. But yes, Deepti, what Dr. Bhavani said, that in a donor cycle, we can go for natural cycle IUI. If you've monitored the patient beforehand and you know on what day she ovulates. If you've done her LH study or a follicle monitoring and you know her cycle length is 28 days, then you know ovulation should happen on around day 14 or 15. So you just monitor a patient before you take her for IUI, and you see when has she ovulated, and start doing a LH surge 2 days before that. Why will you use the whole kit for 5 days? And then the size would also, maybe it varies from cycle to cycle, but the day doesn't vary so much. So at whatever size she is at on day 13 or 14, your LH surge might come. Deepti, you want to talk? Please talk if you have any more doubts or this is cleared for you.
Hi, ma'am.
Hi, Deepti. Is this clear that if you're going for a natural cycle, especially in donor insemination, then you monitor the patient's cycle one cycle before and see which day she ovulates and what was the size of the follicle. And this you can calculate by her cycle length minus 14 days from the days of menstrual cycle she has. And then you monitor the patient on day 12, 13, 14, 15, 16 alternate day and see when does she ovulate. Okay?
Ma'am, when the LH kit shows it's positive, then the LH surge is there. So we do IUI after 36 hours or 20 hours as
24.
you have
What the guideline says, in 24 hours you can do the IUI, but 36 hours also should not be late, because you know that the egg life is 12 hours. So if 24 plus 12 is 36. So till 36 hours the egg will sit in the tube waiting for the sperm to come and fertilize it. It will start
Also,
disintegrating only after 16, 18 hours when it doesn't get the complement chromosomes from the sperm. You understand? So you can do it at 24 hours, you can do it at 36. I feel 36 should be better. What do you
okay.
feel, Deepti? You feel 36 would be better because the egg is sitting and you definitely know that she could have released, though there are few patients who also release it in 2 days, the egg. Dr. Nisha. Bhavani, what is the next question?
And Dr. Nisha wants to ask, do you prefer to confirm ovulation and then do IUI?
It is better, but if you're doing it at the time you've thought, like you've given a HCG trigger and the ultrasonologist after 36 or 40 hours does the ultrasound. In our case, always we call them in between 40 and 44 hours. They do, and you still see the follicle sitting. There is a very fine line in knowing whether the follicle has ruptured and then reformed or it has not ruptured. So don't postpone your IUI. But it is best if you can do it after a documented rupture.
And ma'am, what is your opinion on doing a double IUI in such cases where ovulation is not documented?
We don't know it has ovulated or not. You understand? So the best is do a progesterone and see if the progesterone has started rising, then where is the role of double IUI next day? right? Because a
Yes.
lot of times ultrasound cannot talk about the unruptured luteinized follicle. And if it is unruptured luteinized, then it's not going to help. So many times ovulation has happened and the patient has come running that, my ovulation has not happened. And you are doing IUI. What will happen? I said, just have the IUI and have natural intercourse, and she comes back pregnant. So do not just base your IUI timing on the ultrasound, but yes, it is always better if you can confirm ovulation on ultrasound. That means you can see the follicle is gone. But a lot of time it reforms and it reforms the follicle, and there's no difference in size. So you feel that it has not ruptured. So don't postpone your IUI. Okay?
Ma'am, Dr. Madhura has a clinical scenario that if we are doing an IUI for a PCOS patient and after starting FSH 75 units for 5 days, on day 8 we see that there are multiple small follicles less than 10 mm, then what should we do? Should we abandon the cycle and stimulate her with a higher dose in the next cycle or do something in the same cycle?
Madhura, tell me what would you do? Or someone tell me what would you do in this? Bhavani, you tell me what would you do? After 5 days, you see multiple small follicles less than 10 mm. What would you do?
Nothing,
I will
continue.
see the E2 levels and
Correct. I would like to do a estradiol levels, and I normally for all PCOS always do a baseline E2 so that I get a very good idea. If the E2 is still dwindling in the baseline, increase your dose. If it has increased significantly, doubled, please do not increase your dose, and you need to monitor again, and you may need to decrease your dose also by 25 units or by
वो निकालो
even
नहीं
12.5 units. Bring it to 65,
मैं
Madhura.
बंद कर रही हूँ मैं
Okay.
बंद कर रही हूँ इसको
So do a estradiol test. Do a estradiol test if you are undecisive about to go ahead with the same dose, increase the dose, or reduce the dose. If the estradiol has increased significantly, with caution, continue with the same dose. If it has not increased at all, be confident to increase your dose. But then now the monitoring should be faster, because this PCOS patient you are taking for IUI because you have made her ovulate and she has not conceived naturally. She doesn't deserve to go for IUI if you've not ovulated her before. So you already know her cycle. You know that she ovulates or does not ovulate. And if you are not confident about the multiple follicles, please use letrozole in these cycles.
ma'am, Dr. Meera wants to
So
know
see,
any endometrial thickness cutoff that you consider for trigger
Oh, I wish there was
IUI
a slide
cycle.
for endometrial thickness. I could have shown you. Wait. Let me see if I can find. I had a slide which I did not show because I thought it was unhide करती हूँ. I will show you unhide slide. Now I'm just moving this chat box. How do we move it? Can you see my slide? Can you all see the slide?
yes, ma'am.
Yes, ma'am.
Okay. So how you see this big chat box sitting in front of the slide, or no, you don't see it?
No, ma'am. No chat box. Only slide.
Okay, I can't see because the chat box is sitting right in the middle of it. How do I get rid of it? Okay, so does endometrial thickness affect the pregnancy outcome? The conclusion is endometrial thickness is not a good prognostic factor for IUI treatment success, because this had pooling of 7 relevant studies. Numbers were good, 1,525. There was no association between endometrial thickness and pregnancy rates. And please understand, endometrial thickness is important if the patient has had previous assault to her endometrium in forms of some surgery, DNCs, suction evacuation, anything. If she's not had whatever endometrium she makes on the time of ovulation, whether it is 5, 6, or 7, is her natural endometrium. Patients with unicoordinate uteruses, patients with bicoordinate uteruses, and patients with all Mullerian anomalies have lower endometrium, but their pregnancy rates are as good as. Okay. Okay, now the box has gone. So treatment with CC had significant thinner endometrial thickness than women treated with gonadotropins. with a confidence interval between 0.6 to 0.01. However, pulling up the study showed no association between endometrial thickness and pregnancy rates. So please understand, don't get crazy about the endometrial thickness. Let it be where it is, especially if the patient cycles are, if the uterus is a virgin uterus where no pregnancy, no myomectomy, no polypectomy, nothing has happened, no septal resection has happened. So whatever endometrial you see is her normal endometrium. And before doing a IUI, I mean, you call her unexplained infertility when you've already seen her before. You've done a number of maybe ovulation induction cycles, or you have just seen her natural cycle, seen whether she ovulates, they have the right time intercourse and all. You know the endometrium of the patient. So nothing should make you stressed because you've used clomiphene or you've used letrozole or you have used gonadotropin. All the endometrium, which is 6, 7, 8 mm, will implant. So don't just make the endometrium your line of distress and controversy. Okay?
Ma'am, another common practice is adding oral estrogen. Many clinicians add oral estrogen when endometrium is thin.
I don't think that's a very good practice. Um, and I feel that it is, oral estrogens will not do anything when already you are giving either gonadotropin or clomiphene, and that is increasing estrogen to such high levels. Letrozole is not really recommended much, but I think its use has come in IUI cycles where there are hyper responders and where on letrozole also you would get two dominant follicles. Letrozole, on the other hand, the mode of action of letrozole is by suppressing estradiol production. And here you are giving her estradiol. So the pituitary feels, oh, I don't need to be secreted anymore. The FSH feels that I don't need to come from the pituitary because there is enough estradiol in circulation. So whole motive of using letrozole is lost if you give estrogen. Clomiphene, what are you doing already with clomiphene? Estrogen levels are high. Clomiphene sits on the estrogen receptors. It's blocked some of the receptors, so endometrium will not grow. And gonadotropin, in any case, estrogen levels are higher than what in natural cycle is. So I don't think that you need to add any type of progenova in these cycles. Please understand, if you use just one ovulation induction drug, believe in that, just give that drug and your patient will do the best. I have followed this all my life. I have taught my juniors this and they all will vouch that this is what I do in my practice. I don't write a second drug. So do that and you'll be much better.
Dr. Sushma wants to know any role of agonist trigger vis-a-vis HCG trigger in IUI cycles.
No, but why would you want to give a agonist trigger unless you've hyperstimulated? If you've hyperstimulated, please don't do anything. Let the cycle die off. And if you feel that, say what may, I have to do IUI for her, she's not getting pregnant, you can give a agonist trigger expecting lower pregnancy rates. But here, if really you've hyperstimulated your patient, I would recommend please leave the cycle alone. Don't give a agonist trigger. The luteal phase is not as good, even if you support it with progenova and gestone and small doses of HCG like 500 or 1000 units. So, Sushma ji, please don't, in IUI, leave agonist trigger alone. In IVF, you can give it.
And Dr. Meera wants to ask that follicle size difference is there for trigger depending upon letrozole and CC, and why is it? Because I've heard some seniors tell that around 20 mm for CC should be the criteria for giving trigger.
See, Neera, right? Neera, I feel that when we give gonadotropin's antagonist cycle, the criteria is when a follicle is 17, 18, it is fit for trigger. When we give agonist long protocol, we take our follicles till 22 mm. Similarly, with CC also, if you see a natural cycle, you will see the LH surge comes much later when the follicle becomes bigger. What is our intention in letting the follicle be 17, 18, 19, or 20 or 23? We want that there should be cytoplasmic majority along with the oocyte maturation. So these two things happen with the size of a follicle. And hence, whatever the natural cycle does, you can very safely take your cycles to that size with clomiphene or letrozole. And if they rupture at a lower size, we are not there to stop them from rupturing because we are not giving them antagonist or agonist to stop their rupture. When we give antagonist, agonist, then we have a side to decide. And in that, antagonist size is 17, 18 and agonist is 20 to 22. Whereas with clomiphene or with letrozole, let the follicle rupture on its own because you've made just 2 follicles. Let the LH surge happen. Still, if you want to give the HCG, you can give it at a size when you see naturally her follicles growing and rupturing, which is generally more than 20 size. Okay, so just understand that a natural rupture will happen in between 20 to 25 anywhere. So with CC also you take them the same way. With letrozole also you take them the same way. Give a trigger only if you think it is required. If the LH surge has started, do an IUI 30 hours later.
Ma'am, Dr. Megha
Thank you,
wants to ask, what are your views on for checking perifollicular blood flows for timing the trigger?
Megha, I think if we make the cycle a little less costly, IUI will have its real value. You can definitely see the perifollicular PSV and RI and see that when the vascularity is best, you give your trigger. But where is the expertise of doing it and where is the cost of doing it? Look at a good size and give a trigger for a IUI pregnancy rate where everyone says 15% pregnancy rate or 18% or 20%. If you're going to do everything, you are going to make IUI as expensive as IVF. But you can do this. There is nothing contraindicated. You can do a PSV and RI and then see when the follicular blood flow is best. You give a trigger, but do not increase it because you have to understand that as an IVF specialist, most of the people I've heard in conferences saying that they do very little IUIs because they get very poor results. I love to do IUIs. Bhavani told you that I'm very fond of doing. If I do 100 IVFs, then I do 100 IUIs a month also because I've seen good results in these IUIs. Our paper published showed 26% results with gonadotropin. So, and that is just on a follicular size. But you must know the patient size before you take her up for IUI. Do one cycle of just no medicine monitoring. See how she goes if she's of unexplained infertility and at what size she ruptures, what day she ruptures, and that will give you a very good idea in the next cycle when you take her up for IUI.
Ma'am, Dr. Shweta wants you to repeat what is the best time to do urinary LH.
See, Shweta, the urinary LH, if you look into the articles which have come up, they say that LH surge starts by 12 noon. So we normally tell women who go to office if they can do a LH surge test by 4 o'clock or 5 o'clock when they are coming back and they find the surge, 50% of them will find it then. Whereas early morning, only 25 to 30% will find the surge because the surge uh, should have started in the late night or early morning hours. And in the night, surge has to start somewhere in the early evening, which all of you is for that which is the best time to do urinary LH surge because LH surge starts. And then when the values are more than 20 MIU, that is when the stripe, the LH surge strip urinary catches the LH as positive. Then what do we do when we encounter thin ET in letrozole? Yes, letrozole thin ET is so common. Everybody talks about clomiphene thin ET, but I have seen letrozole having thin ET. Do nothing. Just wait, Naina. So this ET will pick up. And by the time the embryo implants over there, first you'll have the ovulation in another 2 days. Then you will have the embryo implanting. The ET will pick up because the estrogen receptors are upregulated in a letrozole cycle. There are 3 things which happen in a letrozole cycle. Estrogen receptors upregulated, estrogen levels are low, and 3 is that the action time is smaller. It doesn't extend like with clomiphene for till the next month. So these are 3 important things that you remember that the endometrium can be low when you are thinking that the LS surge is happening or when you are giving a trigger, but it will pick up because E2 receptors are upregulated. Next 5 days, it grows into a beautiful endometrium.
And Dr. Sharda wants to know that is it okay to do IUI after 7 to 8 days of stimulation, focusing on the endometrial receptivity?
See, nuclear maturation, cytoplasmic maturation, it takes a little time. So if your follicle gets ready very soon, but before 5 days, you'll hardly find a follicle to get ready. And the patient cycle is 26 days. Give her something like you give in IVF to sort of prevent a early selection of a follicle in the luteal phase of the previous cycle. Don't let it happen. Give her a OC pill if she's got very short cycles. And then the cycle will take its time to grow if she's not got premature selection of a follicle. If there's already premature selection, definitely by day 7, your follicle will be ready because it's been selected in the luteal phase on day 25, 26 only. So ideally, the follicle is growing for the last 10 days. And here there is a lot of disparity between the endometrium and the follicle maturity. So it is good to, sort of give
And
a pill in patients who have very short cycles and your follicles get ready very fast.
Dr. Ela wants to ask what to do if no rupture occurs with HCG trigger.
I don't know how does Ela, is this Ela the one who worked with me? Which Ela is this? Ela, can you unmute yourself? Hello?
Dr. Ela, are you there?
Okay. Anyway, what to do if no rupture occurs with HCG trigger? Rupture is a finding of ultrasound, and ultrasound cannot detect with surety whether a rupture has happened or not. The only way to confirm a rupture is put in a laparoscope and see a ostia if it has opened or not. So a follicle which was 18 or 20 millimeter and after HCG also shows the same size could be a luteinized unruptured follicle or could have ruptured and the wall sealed to make the follicle look the same what it was before rupture. So both the things can happen. Don't stop anything. Don't repeat the trigger. Don't repeat the IUI. Do the IUI in the given time. Tell them to have intercourse. And if you see this phenomena too often, put in a laparoscope and see whether there is anything inside, which could explain the luteinized unruptured follicle.
Dr.
No
Priya
role
wants
of petrolix in gonadotropin IUI cycle. No role of antagonist. You read my paper. This was published in, I think, 2016. We used on one arm antagonist in all the cycles to control the LH and then gave the HCG trigger. In the other one, we gave a HCG trigger without LH surge. And on both arms, we got similar pregnancy rates. So I don't think there is any use. And then now literature, there's enough literature. My studies included in the big review meta-analysis of 2018, where they said that antagonist and agonist have no role in IUI cycle.
again, ma'am, Dr. Devyani wants to ask what to do in case of LUF.
Do a laparoscopy if you see this phenomena happening in 3 consecutive cycles, or it happens once and then you see it again in 1 or 2 cycles later, you find the same thing. Then you have to put in a laparoscope to see whether there are adhesions, whether there's endometriosis. Sometimes LUF may happen in an absolutely normal pelvis, but then it is not recurrent. It happens once and it doesn't happen every time, which is better within letrozole. Out of these, I think letrozole is good if you can make multifollicular growth for women with unexplained infertility. But if you make just one dominant follicle, then clomiphene is better. Khushbu Goyal, where are you? Are you into so much of advanced infertility methods to use GCSF prior to trigger? Where are you going, bache? You have to stay on the ground. How do you do IUI for patients with history of LUF? Confirm that she has LUF. See if she's had a laparoscopy. And if she's having recurrent LUF or she has endometriosis, convert her into IVF, where you can take out the trapped egg rather than giving GCSF prior to trigger.
Dr. Shubha wants to ask why is gonadotropin IUI more successful than IUI with oral ovulagens? Is it just
Or
the
your
number of follicles increasing or more competent oocytes also with
This
gonad?
could be all the things. Why do you use gonadotropin in IVF and not use clomipene in hyperresponders? There also you can get 10 eggs. The only reason is in a IUI cycle, pregnancy has to happen in the fresh cycle. And we need a good endometrium. We don't want the estrogen receptors to be blocked by clomipene. We don't want the endometrium to be thin with letrozole. And we want that good competent oocytes also should be created. Gonadotropin has this quality that it only works as a pituitary gonadotropin. So it will only work on the ovary to stimulate the growth of follicles and the endometrium simultaneously. There's no negative effect on the endometrium, no packing off by the anti-estrogen of the estrogen receptors of the endometrium. And like letrozole, some people are worried that it has a thinner endometrium, and they don't understand that upregulation will bring that endometrium to normal. But then letrozole has this problem that it will not make two dominant follicles in most of the cycles if there is unexplained infertility with normal response.
Ma'am, Dr. Ashna wants to know if there is any role of using a combination of clomipene or letrozole
No.
with gonadotropin.
No, nothing. Use one drug and use a drug which will give you two follicles. If that drug has not given you two follicles, then change the drug. If CC is not giving you two follicles or letrozole is not giving, if you want to use only oral, use letrozole, one dominant follicle, next cycle use CC, one dominant follicle, change over to gonadotropin. You don't need a lot of gonadotropin, hardly 7 or 8 days of gonadotropin is needed in IUI cycles with unexplained infertility because the cycles are like 28 days. You start on day 3 or 4, by day 11, a good follicle is made. So if you start on 4, 4, 5, 6, 7, 8, 9, 10, you use 8 days of gonadotropin only. So please don't think that cost is going to be very important here, because when people can think of GCSF prior to trigger, or you can think of so many other things of doing, what was it? Someone said, what do we do? Cetrolix or GCSF, or you do something else. You don't need all that. You just need a good gonadotropin cycle, and gonadotropin's HMG is really cheap. You can get it for 300-400 a day. 7-8 injections will not cost more than 2,000 rupees or 2,500. Please go for gonadotropin, not recombinant, but go for urinary gonadotropin if your patient or you are not comfortable prescribing expensive ones.
Ma'am, Dr. Shreya wants to ask, is there any role of checking serum E2 in IUI cycles?
Well, I like to do at the start of the cycle and at the end also, but a lot of people don't recommend. And especially if you make two follicles only, then there is no need to check serum E2 in IUI cycles.
Ma'am, Dr. Latika wants
Latika.
to ask about the progesterone support in IUI.
Now see, Latika, if you've made just two follicles, two follicles, maybe progesterone support is not mandatory, but a lot of times the body only produces enough to support one good follicle. So it is good to give a little progesterone, especially if you've hyperstimulated your patient and you have 2 or 3 follicles which are there, then it is good to give progesterone. I like to use only vaginal progesterone. That is my mode in IVF and IUI. I've never given oral progesterone or dufestrone or anything like that. Injectables are very painful, and all of you who've taken it yourself will experience what the pain is. So it is best to use vaginal progesterone. If you counsel your patient, patient will take it very easily. You can use these pessaries rectally also, which is used in Europe very widely.
Dr. Sushma wants
Yes,
to
Sushma.
ask.
Yes, please. What do you say, Bhavani? Tell them what is your opinion.
Yes, ma'am, we should advise natural contact for 2 to 3 days.
Because see, if your IUI is ill-timed and you have stimulated her well, she could get pregnant just by intercourse. So before and after, not only after, you tell them if the husband is confident, he'll be able to give a sample today. He can have intercourse the previous night also, or on the day of HCG trigger.
Ma'am, Dr. Priya has a clinical scenario. In one of our patients, we had 2 follicles of 16 and 16.5 mm and 1 follicle of 12.5 mm. What to do? She was given FSH 75 letrozole for 5 days.
You tell me, what will you
She
do,
already
Priya?
has 1 child.
Priya, tell me, what do you want to do? What does that woman feel? She's an intelligent patient who's asking you this, that I have one live issue and I don't want two children. Cancel the cycle. And in IUI, if you're doing, tell her that there is always a chance of having twins, because even two follicles can lead to twins.
Dr. Archie wants to know any role of doing IUI under ultrasound guidance.
No, I don't think there is any. If you are sure that your cannula has gone in, it's gone in. And you only have to spread the semen sample into the uterine cavity beyond the internal os. It has to go mostly towards the cornua. It is important to keep the cannula in a way that the two butterflies are on 180-degree east and west, because the two holes will be parallel to it and they will point towards the tubes.
Dr. Devyani wants to know if we can do HSG in the same cycle as we are doing IUI.
Yeah, you may do if you can do it early by day 5. What is everyone's opinion? Someone else wants to answer, please answer. Bhavani, can you do HSG in the same cycle? I think yes, we can do. There's no
We can.
harm. Yeah. And in fact, when we are doing a HSG, then for IUI, we give clomiphene. We don't give
We avoid
gonadotropin.
gonadotropin.
Because if the tubes come out blocked, then all the gonadotropin is gone wasted. And you do HSG by day 6 or 7. You've already given 3 or 4 days of gonadotropin by that time.
Dr. Pujita wants to know role of tamoxifen as an oral ovulation.
Very good, Pujita. I want one of you to use tamoxifen and publish a paper on tamoxifen. The dose is 20 milligram twice a day, and it is really a good drug. I've used it sometimes to make the endometrium also. But when I find the endometrium for FET low, then the best drug I find is gonadotropins. Low doses, just to make the endometrium.
Dr. Chaitanya wants to know that should the dose of HCG be doubled if we see two dominant follicles?
No. Never, never. In IVF, you see 20 follicles. You still give the same dose of HCG, 5,000, or Ovitril, 2.5 microgram. Please do not ever double the HCG dose if you see two dominant follicles. HCG 5,000 is good enough for one follicle. It is good enough for 20 follicles.
Thank you so much, ma'am. We have completed the
Okay,
question.
we've had very nice question answers this session, and we've overshot our period, and I think I started late, so I'm sorry about it. But we've had such good question answers, but why did anyone not unmute herself and talk? I would have been very happy if I would have heard your voices, but thank you so much for hearing all this and taking the tips and giving everyone the clarity by asking these questions.
Thank you so much, ma'am.
Okay. Thank you, Bhavani, for being there. I think it's good to see everyone, and so happy to see all of you there. Okay, bye-bye, good night. Next Thursday, there's no meeting. We'll have next to next Thursday. Next Thursday, I'm going for UP-COG. On Thursday only, I'm leaving. And in any case, we've decided that 3 classes and 1 off, and then 3 classes and 1 off. So that's how we'll go. Thank you so much, Manas. And thank you, Mr.
Thank you, ma'am.
Thank you for bearing with me. I don't know why my computer hung today, so I don't think it will hang